Coming up.
Well, I was never going to give her a pacifier, and then she got a pacifier from my mom. And she is so obsessed with her pacifier to this day. When she turns 2, the pacifier fairy is coming to our house. I'm the one having a problem thinking about my child suffering from getting rid of her pacifier, even though I know the implications of getting rid of this pacifier and getting her more obsessed with her munchie. She kind of likes her munchie. We're like going to go full in on it, right? Because of those like implications.
We're just talking about the long-term implications. We all have choices that we can make in our lives, and knowing the consequences and being able to choose is a big part of that.
Even as a dentist, we are taught that there is increased risk of orthodontic problems. And so for me, I thought, okay, I'm not going to use a pacifier. But at that time, my oldest, she's 15 and a half, I did offer a dummy or pacifier because it really helped soothe her.
Oh, yeah.
It made a difference for me to go out and have a shower at that time. And I thought, it's all about the teeth. I can't see, I think you'll be okay. But really not understanding what are the full implications of this dummy, and ended up using it 2 or 3 years. And even the child health nurse told me, go and get this big fat dummy. These are the cheapest ones. This will work really well. And I wasn't even educated enough to not listen to that. And to now be able to try to impart this knowledge to parents to understand that, yes, it's about the teeth as well, but it actually affects their whole tongue posture, their whole swallowing, the way that their mouth works. And it really could be a sign that there's an underlying issue if they have to rely on the dummy, and we can address that better. Well, they actually alter the tongue posture, so they push the tongue down, and we actually want the tongue to rest against the roof of the mouth, and that's really optimal for good palate development, and it's really important for good tone of the tongue and to block off the nasal breathing route. And so the problems with pacifier use are going to be linked to the frequency, intensity, and duration. So really understanding that the more we can limit the use, the better. So if a baby is really unsettled, we don't need to leave it in their mouth. We can actually just soothe and remove. And when the tongue is down, it alters the swallowing pattern. So there are increased risk of ear infections because the eustachian tubes can't drain correctly. We also understand that we need free tongue or the tongue to sit in the roof of the mouth and stimulate these palate receptors. That sensory component is really important for speech perception as well. And so speech delays that can be linked to prolonged pacifier use as well.
We have a special offer for our Munch Bunch listeners. To book a virtual consult with Megan, she's offering a discount of $25 off. Just email her, Megan, at nwmyofunctionaltherapy.com or through her website, www.orofacial-myology.com. To book a virtual consult with Kimmy for the $25 off, email her mouthmusclememory@outlook.com or through the website, www.mouthmusclememory.com. Now on to the episode.
Hello, everybody, and welcome to the Munch Bunch podcast. Megan Vanoy, your co-host with Kimmy Nishimoto, myofunctional therapist and besties. And we are so excited today. Our guest is not just a doctor, but also an author, Dr. Shereen Lim, and she wrote the book Breathe, Sleep, Thrive. And we are so excited to talk more about the new book and to just pick her brain on all things, basically airway. So before we do, as you guys know, we have started pulling our affirmator card. So Kimmy, pull the card.
Okay. Dr. Shereen, I'm going to let you tell me when so you can be included in everything.
Yes. Okay.
Now?
Okay. Grace. I face disagreements with grace and flow through the ups and downs of my relationship without getting thrown off center. Woof, that is hard. With grace, I'm able to keep my cool, be my best self, and not resort to name calling, even when that crappy poo poo face is being a douchey barf monster.
Yes. And I think actually that could really relate to what we're talking about today, right? Because a lot of times as we're talking, maybe not like the douchey, crappy fart monster or whatever that was, but like lending grace of the things that, like we say this to our patients and, all the time is we don't know what we don't know. We see so much mom guilt. We see so much even like just in general adult guilt of like, man, I wish my parents would have addressed my airway issues when I was a bedwetter when I was 7. Right. Or, oh, my kid's 5 and I didn't know about this stuff. I wish I would have known when they were 2. So I think in our field, we do have to extend a lot of grace and grace for ourselves for, hindsight's generally 2020. So what we know now, can lend a lot. So, okay, Dr. Shereen, tell us more, about you, where you're located, what you do, what your practice is, and what inspired you to write this new amazing book.
Right. Yeah. So I'm a general dentist and I'm based in Perth in Western Australia. And so the main things that I focus on in our practice is infant tongue-tie management from infancy through to adulthood, involved with myofunctional therapy and palate expansion for young children, as well as tongue-tie dental sleep appliances for adults as well. And so really I got into this area 12 years ago, prompted by my husband snoring. It was really frustrating me. So I decided that I was going to learn more about dental sleep appliances and how to help other spouses out of this situation as well. So I actually did a dental sleep medicine qualification and became involved in treating adult snoring and sleep apnea. And what I realized was that a lot of adults that have these problems, they're actually not living life to their full potential. A lot of brain fog, memory concerns, struggling energy-wise, depression, anxiety. And we have really missed that boat to identify the breathing issue. But when I see the adults that are referred to me for snoring and sleep apnea for the dental appliances, we can really start to understand it's a craniofacial problem. It's a problem with their jaw development that we're actually trying to band-aid to get them a better night's sleep with these dental devices. So I wanted to understand how come we can't grow the jaws properly in the first place. So in dental school, we're taught that you can actually develop the jaws at age 7 to 8 years with interceptive orthodontics. But yet, when I was referring to the orthodontist, they wanted to say, why don't we just watch and wait until a child is 12 and then we can treat it more efficiently. But I did learn from the sleep medicine course, the work of Dr. Christian Gimeno, when we can do palate expansion, it actually improves nasal breathing and sleep. And so it really made sense. Why are we not doing this early interceptive orthodontics? And so that's when I decided that I was going to learn how to do it myself. I have young children. I wanted to do it for them. And now I wanted to introduce it into our practice. So what do we tell parents? Why are we doing this differently? We sent your other child to an orthodontist. They took out teeth to alleviate dental crowding. Your child has a beautiful smile now. Why would we want to do it any differently and start early? Yes. and so it's a really difficult conversation if you can try to imagine trying to connect all these dots for parents. And so that's what the book was about. I first thought of it around the 6-7 year mark when I first started to introduce early orthodontics into our practice. But then really understanding that poor jaw development is a reflection of poor orofacial muscle function, and that there are many other opportunities very, very early on in life from infancy in the way we feed our children that can alter that trajectory of development. And so that's really why I wanted to write the book, to highlight the importance of healthy jaw development, as well as what can parents do and what are the red flags when things are off track with their jaw development or their breathing and their sleep as well.
That's beautiful. And I love that you saw the need and then was like, I'm gonna do it myself. If I'm gonna refer to you and you're just gonna tell them to watch and wait. No. I love that.
Yeah, there is no one else that I really would have wanted to treat my own children. So that's how it all came about.
Yeah, it is such a hard space. And it's funny that you're like, yeah, my husband snored and that's what got me into this. Like my dad snored and that's what got me into this, right? But now like it just is like opened up such a bigger world. And when I had Isabel, I had to put on my mom lens and I had to look at some of these things. And we tell parents all the time, it's so much better if we can get it done earlier, right?
Yeah.
Prevention is so huge. And I think in a lot of ways we do understand that, but I think sometimes as a parent, and I've caught myself in this, Izzy's 2 next month, you guys. On the
she
7th of
really?
next month. I know it. But you hear so many things, right? And you have to be like, okay, but like, what's best for my child? What, like, this person over here is telling me I should do this. This person over here is telling me I should do this. This person is, my mom, which is a terrible example because my mom is a rock star, but my mom told me she never did this with me. And, I'm fine, right? And it just can be, parents can kind of be alienated when they do something quote unquote different. And so I think all of you guys out there who are coming out with these books and with the research, like, especially now that I've become a mom and have a new lens, like, just thank you for making everybody else not seem so crazy.
Yeah. And these are complicated problems, and it's not just a one single thing fixes everything. It usually involves an integrative approach, and sometimes it's over a long period of time. There's lots of different things that we can actually do. And so I think it's important for parents to understand we may miss one boat, but these are the other things that we can actually do, and these are the pathways that we can take.
Yeah, and I think that's beautiful. I've had several people send me this meme over the last few days, because everybody who listens and everybody kind of in my close circle knows that I really struggled through breastfeeding. I had milk production issues, so I had to bottle feed Isabel, despite everything we tried to do. And there's been several people who sent me this meme that's been going around, like, my kid just got a face tattoo. Go ahead and bottle feed yours. Like, go ahead and bottle feed. It doesn't matter, right? And of course, like, I think it's hilarious, right? But it's like there's never one perfect way, but taking what we know and what we know now and being able to apply that, I think, is so powerful. So in your book, obviously you've got, which actually, you guys, if you're just listening, that's okay. But if you're watching, she's got a lot of great illustrations and stuff. And I think being able to see things, and I know you've got some case studies in here that I was looking at. And I think being able to see some of this stuff really helps with that connection. So I think that's so great that you included so much of that within that. It's really easy to read. It's like you can understand it. And I just think that is so key when this is something that's so new to you.
Yeah, for sure. And it took me longer than I thought it would, because it really, first version came out looking like a textbook. I'm like, here, it's done. And yeah, people said this is a little bit textbook, and that it was so worth the pain and the struggle through it, because that's what people say. It's readable, it's easy to understand.
And that's our whole vibe, is like, how do we like explain this stuff in a way that the average person can understand and take something away from? So that's good.
Yeah.
So one of the points in the book was like how a myofunctional disorder could be an early warning sign of an airway problem. So can you talk to us more about that?
Yeah, if we can understand that these sleep disordered breathing, the restricted airway, one component is having a small airway and the skeletal, or the jaw structure, that actually forms the outer box and the floor of the nose and the house for the tongue. And so the way that the jaw structures grow, well, firstly, the jaw structure growth peaks in the earliest years of life. 60% of it is done by the age of 6 years. And it's actually influenced quite a lot by how the muscles work. And so the ideal stimulus for the jaw muscles, for the jaws to grow properly, is to have good tongue suction, the tongue resting on the roof of the mouth, and the lips closed, jaws together, and breathing well through the nose. And when we have that go off track, that's when we develop other compensations. With, like, for instance, breastfeeding, it's really a marker of good orofacial function. It's actually the way that the tongue is supposed to work. It promotes nasal breathing. It promotes good jaw development, good jaw function, and function of those masseter or chewing muscles. And so when those things start to go off track and we develop those other problems, with whether it be picky eating, breastfeeding problems, speech concerns, or all those things, those muscles are not working correctly, and they're not providing that functional stimulus for the jaws to grow early. And so I wanted people to recognize, we all recognize that high arch palates and receded mandibles, they are linked to increased risk of sleep disturbed breathing. But what are the root causes of those problems? It is the poor muscle function, starting with tongue ties and mouth breathing. And whenever we have the muscles not working properly, it also means that the muscles aren't going to be working properly during sleep as well. And so, yeah.
I think that's such a good point, because people often are like, well, they had a tongue tie, but they could breastfeed, so it's fine. But it's like, those kids, they often are not the best sleepers, or they grow up to be the teeth grinders or the bedwetters, or they don't sleep through the nights, or they have to constantly get up and get into mom and dad's bed, and then they're kicking mom and dad in the head. It's like, yeah, they could breastfeed, like, quote unquote fine, but it's still not fine for everything else.
Yeah, I think a lot of people say that they breastfed for so long, but the thing is, even if you have a tongue tie, you can still breastfeed quite often, but you compensate. So rather than using your tongue correctly and your jaws correctly, you actually overuse your lips and cheeks and develop poor swallowing patterns as well. And so I think a lot of people don't recognize that. But we need to be paying attention to having a good optimal latch and making sure that tongue is working well, because that is tongue training for everything else that we need it to do, to develop that tone, to develop the palate properly, or to form that seal against the palate so that we can promote nasal breathing, or, the tongue, recognizing that the tongue is the most important upper airway dilator muscle, or the genioglossus, that forms the bulk of the tongue. And so that needs to work really well. And if it doesn't work well, we continue to compensate, but it's nighttime when those problems are expressed, because during sleep, all our muscle tone is reduced, and that's when we start to see those issues play out. So untreated tongue tie will be linked to the development of these issues down the track.
Yeah,
and I'm so excited.
Yeah, I love that, and I think too, it's like, oh well, I breastfed fine and I gained weight fine, and they're just such blanket statements, right? Oh well, she's just was the heavy sleeper, or it's cute when my kid sleeps with their mouth open, and and if you're like, hey, actually that's not safe, and then it like creates that like defensiveness of, well, my kid breastfed fine, right? Or, well, my kid, and that's okay, and that's great. I'm glad those things happen, but kind of where are we at now, and what are we seeing now? And I think that is, kind of that open, having that, again, openness, gentle approach can be really kind of open those things up, right? I had to bottle feed Isabel. I was never going to give her a pacifier, and then she got a pacifier from my mom, and she is so obsessed with her pacifier to this day. When she turns 2, the pacifier fairy is coming to our house. And we're going to do like a whole pacifier ceremony, the whole situation. And part of it is, honestly, you guys, it's me. I hope you guys know that at this point. I'm the one having a problem thinking about my child suffering from getting rid of her pacifier, even though I know the implications of getting rid of this pacifier and getting her more obsessed with her munchie. She kind of likes her munchie. We're like going to go full in on it, right? Because of those like implications. And I'm not kidding you, Kimmy. I don't know if I told you this. My mom told me the other day, she's like, man, her mouth looks just like yours when you were little. It's like, Mom. I was like, and that's why I had to have an expander. And that's why. She's like, and, it's cute.
And, even as a dentist, we are taught that there is increased risk of orthodontic problems. And so for me, I thought, okay, I'm not going to use a pacifier. But at that time, my oldest, she's 15 and a half, I did offer a dummy or pacifier because it really helped soothe her. It made a difference for me to go out and have a shower at that time. And I thought, it's all about the teeth. I can't see, I think you'll be okay. But really not understanding what are the full implications of this dummy, and ended up using it 2 or 3 years. And even the child health nurse told me, go and get this big fat dummy. These are the cheapest ones. This will work really well. And I wasn't even educated enough to not listen to that, and to now be able to try to impart this knowledge to parents to understand that, yes, it's about the teeth as well, but it actually affects their whole tongue posture, their whole swallowing, the way that their mouth works. And it really could be a sign that there's an underlying issue if they have to rely on the dummy, and we can address that better rather than having to use the dummy. So I think I'm quite passionate about it because there are long-lasting implications of the dummy that continue for a long time that we don't really, most parents don't recognize.
Yeah, I think that's a really good point. And I was like Megan, where I'm like, I don't want to use a pacifier because I want their tongue to be their pacifier.
Yeah.
But I'll tell you what, guys, I babysat my twin nephews by myself with the 3-year-old home, and I could not wait to shove that thing in there. I was like, I need to just stop crying. I'm stressed out. So no judges to people that use them. We're just talking about the long-term implications. We all have choices that we can make in our lives, and knowing the consequences and being able to choose is a big part of that. So, Dr. Shereen, will you please tell us what are the implications of using those pacifiers, and what are the guidelines? Because I've heard the guidelines are way outdated. It's way too long, and it already causes a lot of distortion. So talk to us all about that.
Well, they actually alter the tongue posture. So they push the tongue down, and we actually want the tongue to rest against the roof of the mouth, and that's really optimal for good palate development, and it's really important for good tone of the tongue and to block off the nasal breathing route. And so the problems with pacifier use are going to be linked to the frequency, intensity, and duration. So really understanding that the more we can limit the use, the better. So if a baby is really unsettled, we don't need to leave it in their mouth. We can actually just soothe and remove. And when the tongue is down, it alters the swallowing pattern. So there are increased risk of ear infections because the eustachian tubes can't drain correctly. We also understand that we need free tongue or the tongue to sit in the roof of the mouth and stimulate these palate receptors. That sensory component is really important for speech perception as well. And so speech delays that can be linked to prolonged pacifier use as well.
Interesting. I don't know if I've heard that one.
Yeah, there is a research study that said you need free tongue. That tongue needs to hit the spot to recognize those sounds. And so this could be linked to dummy use or even tongue tie. As well.
I knew the tongue tie part, but I didn't know that also extended pacifier use has been connected with speech delays.
I guess it makes sense, though.
Totally makes sense.
Because if you have, a lot of times tongue tie and low tongue tone will mimic each other with their myofunctional disorder. But one is caused by the physical restriction and one is caused by the low muscle tone or low posture. So it totally makes sense.
Yeah. And so there are some recommendations that we should be using pacifiers to actually minimize the risk of SIDS. However, there is some research to suggest that the dummies actually have a protective mechanism or they protect against sleep disordered breathing because it actually creates a suction that actually gets the back of the tongue and the soft palate to connect. And so I think a lot of the time, if we can get the tongue working better, we can actually create that issue. So one of the biggest protective factors against SIDS is to be on the back. But when babies are on their tummy, I'm also starting to think these are babies that are more prone to disturbed breathing. They're actually trying to protect their tongue from getting down the back of their throat. So I think what we're going to find later on is that we may not really need to blanket offer a pacifier to all babies. It may be more protective for the babies that are sleeping on their stomach. The reason why some babies sleep on their stomach, it could be actually linked to poor tongue posture or low tongue posture and basal tongue obstruction of the throat.
Yeah, that's such a good point. And I don't know if anyone super knows though, because my mom was saying that she's been raising babies since the 80s, the 90s, and the early 2000s, because we have a huge spread in my family. And she said that tummy time was never a thing until like later on with her older, like with her younger kids, because she used to just put them to bed on their bellies, and then it became baby on back later on, and then they started having to implement tummy time. So I would be so curious to have like a scientist on that could talk all about SIDS, because it's such a fascinating thing.
Yeah, look, I probably stepped out of my realm of expertise a little bit with those comments, but yeah.
Yeah, we're talking about mechanics and we're kind of seeing how things relate. And, I don't think it's a bad thing to hypothesize. Because Kimmy, actually same thing, like, between my older sister and my youngest sister, there's 9 years. And, if I remember correctly, my mom was saying, like, with my older sister, tummy time wasn't talked about as much. But then, like, when Sydney was born, it started to be talked about more, and more being on the back. And there's only, 9 years, almost 10 years difference between the two. But still, so much has changed. I mean, I've been in this airway space for about 10 years. And so have you, Dr. Shereen, a little bit more, right? And all the things that have changed just even in the airway space in the past 10 years and what we know now, like, the techniques for releasing tongue ties when I first started out, and even how we diagnose tongue ties, it's completely different to now. And, that's not that big of like chunk of time.
Yeah, I think we'll just see how it plays out, because everything changes so often. It's just like one food is good one day and it's not good a couple of years later. So I'll be so curious about the whole SIDS thing and tummy time in the future. Like maybe there'll be a resurgence of baby on belly again. I don't know.
Yeah.
I think what I was really maybe trying to get at is that maybe tummy sleeping is not really protective against SIDS. Right. But maybe tummy sleeping is those children that are more prone to airway obstruction. And I don't know about you guys, but sometimes can you kind of tell which children walk into your practice that actually sleep on their tummy?
Oh, yeah. Sometimes they like just look a little bit crooked, because I think it puts like that pressure on their face.
Yeah. And so for me, usually if I see an open mouth and a tongue thrust, I will ask, do they tummy sleep? And quite often these are the tummy sleepers.
Yeah. Yeah, I think it's just another, like, just kind of like nugget to have in your toolkit of like things to kind of look out for, and even like things to ask. And you were talking about swallowing patterns. And I actually get this question a lot, not even kind of in my patient space, but in general. Just you briefly brought it up, and I want to talk about just a little bit more, how we swallow in ear infections. So, we get this a lot. Well, I had a lot of ear infections as a kid, but I grew out of them, right? Will you talk to us a little more about those mechanics of swallowing and why maybe the younger kids tend to have more ear infections in tubes versus like how that changes?
Yeah, I think that originally children will have a more horizontal eustachian tube that doesn't drain as well, and that sort of corrects as they get older. But I think if we look at ear infections, a lot of people are starting to comment that it is actually eustachian tube dysfunction, where the eustachian tube is not working correctly. And for that eustachian tube to work well, the soft palate muscles need to elevate well to open the eustachian tube. And so poor swallowing, where the palate is not working well, could be linked to poor drainage And so a lot
Interesting.
of children that are having these recurrent ear infections, I think it's important that we look at their swallow. And there is also research to suggest that palate expansion can actually improve improve eustachian tube function and also hearing loss from chronic glue or the accumulation of fluid inside the ears. And they've actually done research on children, I think around the 7 to 8 year mark, where they've randomized children into groups where they have no treatments, treatment with ear tubes or treatment with palate expansion. And they found that the children with ear tubes and palate expansion, they both improve their hearing thresholds and to the same degree. So therefore, the researchers conclude we may as well do the palate expansion. That is the most preferable option because we're getting to the root of the issue.
That's a super good point. Because if you think about like anytime you've been on a road trip and you go high into the mountains or you're on that airplane and your ears are aching and so painful, what's the advice? Either chew gum or do that hard swallow.
Yeah,
you're clearing the eustachian tubes, right?
And so one of the reasons why palate expansion can actually be effective to improve eustachian tube function is that when we expand the palate, we improve the scaffold that the soft palate is suspended from. And so that allows it to work better. But then there are also people that will say that it improves nasal breathing. So that also helps to reduce pathogens, which could be linked to ear infections as well.
Guess what? It's all connected, right? That's what we talk about all the time.
And really understanding that palate expansion can play a very central role in improving nasal breathing and many other things that go with it, whether it be ear infections that go with mouth breathing and
Fantastic.
We want to introduce the Spot for Tots course, a parent's guide for toddlers ages 2 to 5 for Mini Mayo. We have Megan and Kimmy going over nasal hygiene, myofunctional exercises, breathing exercises, tongue tie healing protocols, and then we have Jenny June going over sleep hygiene and Kelsey Baker going over feeding therapy and body work. The course is $297 and the link will be in the description.
So that leads me, ears leads me into my next question here. ENT problems. So ear, nose, throat. In your book, you talk about how ENT problems are a symptom of breathing dysfunction. Talk to us all about that.
Yeah, well, a lot of children that have ENT surgery, it's assumed that they will become nasal breathers, but we all deal with children that aren't converting. And so there is going to be a bigger root issue that we need to deal with. And so one of the interventions that's really effective is palate expansion. So I think when children have surgery, we really need to restore nasal breathing. Right. And so in terms of restoring nasal breathing, we need to address narrow palates because that will actually improve nasal airflow. We need to improve the tongue suction as well as achieve the good lip seal as well. And so I actually look at these problems or enlarged adenoids and tonsils as being a symptom of dysfunctional breathing. And there is actually a hypothesis that's been published by Dr. Howard Stupak, and he's done some experiments using models to look at airflow to validate this hypothesis. But what he's really suggesting is that enlarged adenoids and tonsils could be a symptom of poor palate development. And when we have a narrow palate and we have reduced nasal airflow and nasal disuse, we actually have to breathe harder. So during sleep. And so when we breathe harder and we increase the collapsibility of our airway, that draws in those tissues, the enlarged adenoids and tonsils, and it creates the swelling. So that's one hypothesis. And I tend to agree with this because what we now know is that there is research to support that when we do palate expansion, we get objective decreases in the size of the adenoids and tonsils. And so therefore, there is something happening with that improvement in nasal airflow that is reducing those enlarged adenoids and tonsils. And that could be getting closer to the root of the issue. That's not to say that we should completely avoid taking out adenoids and tonsils for all children, but I do think that there is a space where sometimes children do have to go on a wait list to get an appointment or to get a surgery. We can do palate expansion, and usually like in 5-6 weeks, we can notice that there is going to be some improvements in symptoms. And if they improve quite significantly, we don't need to rush into surgery. There are some children that won't need surgery after palate expansion. And I think that's getting closer to the root of the issue. And we need children to breathe through their nose.
That's a great point. I had another question for you when you were talking about the collapsibility of the airway and that being part of the reason why they swell. What about like silent reflux, where you're getting that negative suction of acid up into the upper airways? Because I've heard that could be another reason why kids or adults could have inflamed tonsils or adenoids, would be like that silent reflux.
Yes, that's true. And sometimes reflux can be actually a symptom of dysfunctional breathing as well. So when we are breathing harder, again, same sort of pathway, we are generating more negative pressures in our throat. And that is going to allow stomach contents to aerosolize up here. And yes, that can also, increase swelling of those tissues. So I do think a lot of these children that have reflux, sometimes it could be breathing related.
Interesting. And it makes sense. And then you're just getting hit from both sides, and those poor tonsils and adenoids just have no chance. Oh, man. And I think, if I were to put back on my dental hygiene hat, which I have not worn in several years, but we're putting it back on, and I'm looking, doing cancer screenings in patients' mouths, I'm looking at the back of their throat, I'm looking at their tonsils, and not necessarily always in that airway space. The very first dentist I ever worked for was a bioblock dentist. And, he was telling me, did you know your tongue's supposed to, be on the, on the spot? And I'm like, what is that? Right. And slowly kind of teaching me some of the things to start looking for. And he's the only dentist I ever worked for in 10 years that was looking at those things. Well, now in the past couple of years since I've been out of that hygiene space, there has been kind of a huge push for dentists to start screening for these things. And a lot of times we get frustrated, especially adult patients. Like, I've been seeing the dentist my whole life, the orthodontist, the regular doctor, they've seen all these people. How come nobody's ever told me this before? Right. And I always make the joke that it's nobody's job to look at the tongue except for mine. It's not it's not ENTT, right? There's no tongue in the word dentist, right? But I do think that there's been a huge surge in these last couple of years that dentists need to start screening for these things. And it's not weird for your dentist to ask you these questions and to screen for these things. So, what were some of these red flags from a dental perspective? If patient was in your chair, if you were doing that, what would you be looking for?
Yeah, well, firstly, I just want to highlight that it is not weird for a dentist to be doing it, because in 2017, the American Dental Association actually released a policy statement suggesting that all dentists should be screening for those red flags and in children, to identify children at risk of disturbed breathing. And so what are the common red flags? Well, I think teeth grinding is one of the strongest red flags. So tooth grinding related tooth wear. We know that teeth grinding can be a compensation to keep the airway open. So there's an arousal from sleep, and then the muscles are activated, and that just keeps the airway open. Looking for open mouth posture, enlarged tonsils that we can have a look at. Looking for tongue tie. How is the tongue sitting? High narrow palates, or any malocclusion. So if there is any cross bites, or there's a retrognathic or or overbites, as parents would call them, where their lower jaw is more recessed. Yeah, thank you. Or any dental crowding, which could be they're all signs that the jaws aren't developing well. And so when the jaws aren't developing well, there is going to be some sort of airflow limitation, and the child is not going to be breathing as optimally as they can. We were talking about reflux before as well, the erosional wear. I think it's quite commonly overlooked, but so many children have these signs of erosion in their teeth. And the children that have a lot of dental decay and problems, a lot of parents come in and they're saying, oh, I don't really feed my children that bad a diet. Some of these children that have multiple decays, what we're really overlooking is the mouth breathing. And I actually think that reflux disease, or this acid inside their mouth, is actually increasing their risk out of proportion to what it should be.
Yeah. I had this little buddy yesterday who I did an evaluation for, and they actually live up in Alaska. Like, they don't have, like, they have a town dentist that comes like once a month to, like, they're in a very secluded area, and they actually flew to Portland because the mom had found Dr. Stacy on Instagram, basically, and so they actually flew to Portland to start kind of working through this airway stuff. They're going to work with us virtually. And because, you know, he's only 5 and he's had so many cavities, and she's like, she's a nutritionist, so her kids eat very well, and there's not a lot of plaque on her teeth. And she had been saying, I think there's something more here, where it's not that we're not brushing and flossing. He eats good food, right? But, you know, she was dismissed so many times and did her own research to find, and we were able to validate her concerns. I'm like, yeah, it's because he's a little mouth breather. Right. And he 100% is. His tongue is low. He can't even lift his tip of the tongue up. He's not tongue tied, but he has such low tone. Even just lifting his tongue up is hard for him. And so mom felt so validated by knowing that, that it's, you know, not because she was doing anything wrong with her kid.
Yeah, absolutely overlooked.
Yeah. Oh, man. But we're getting there. The world's changing. We see it every day. We've been in this space long enough that we have seen things change so much, even in just a short period of time, which is amazing. So, you know, and then we have the other side of the problem, right? Like, we're able to help prevent so much in kids. We're able to help people early. But then there's the rest of us who didn't figure these things out until our 20s and 30s and 40s and beyond. You know, if we would have caught these red flag symptoms when we were younger, yes, that would have been amazing, right? But again, hindsight 2020. So what are some of the things that some of the problems that we see adults see developmentally when that kind of airway growth gets off track?
So what happens with adults? You know, the most common symptoms that I hear adults describe is brain fog, memory concerns, anxiety, depression, you know, high blood pressure. It's linked to virtually, increased risk of virtually every chronic health condition, whether it be cancer, you know, heart problems, strokes, dementia, diabetes, virtually everything. It's important that we get good quality sleep, and we need to pay attention to how we're breathing, because that dramatically affects the way that we sleep. And whereas in traditional sleep medicine, or in sleep medicine, it's really focused on treating the end-stage problem, obstructive sleep apnea in adults, and how can we give them CPAP, and how can we give them mandibular advancement or devices or dental appliances. But really, I think that those are Band-Aid solutions, and we really should be trying to offer, or at least offer, the option of restoring nasal breathing for adults. And sometimes that's going to involve exactly the approaches that we use in children, with developing the jaws through palate expansion or MMA surgery to develop the jaws forward. But it's a lot more complex to deal with. And so I see in my practice all these adults that they're really struggling. They may have this depression or just brain fog, and really be dragging through the day, and they've got the narrowest jaw, and they've had teeth removed, and like sometimes they have a tongue tie, and they've got the chronic neck tension and the headaches, but you just actually can't release the tongue tie because their mouth doesn't have the space for their tongue to work properly. And we could potentially aggravate their breathing disturbance because their tongue has nowhere to go but back. And I think it's important for people to recognize that these are the line problems if we don't address it properly. So we need to focus more on airway health and reinforcing or securing nasal breathing for everyone as early as possible, and making sure the airways grow well, which means that in the earliest years of life, we need to make sure the muscles are functioning well to provide the proper stimulus for the jaws to grow well. And with orthodontic treatments, treating crooked teeth with braces or taking out teeth, we're not really addressing that poor jaw development.
Right.
And so we need to develop the jaw well early on, because it is quite despairing. I often will say that when we're involved with tongue-tie management from infancy, there's so many problems that go with when the tongue-tie is dismissed, or families really, really struggle, babies struggle. Or sometimes when the children are older and they're having poor sleep and ADHD or behavioral concerns, and it impacts the whole family dynamics, and they're all despairing conditions or problems. But the worst thing for me is seeing the adult who has had this struggle for years and years, and seeing the jaw problem and thinking we could have actually dealt with this along the way if actually parents just knew what are all the things that we need to look for. And there's so many things or opportunities that we can actually intervene or set up from the very beginning, if only people know.
That is such a good point. I've been thinking about this too, because I've had some severe teeth grinders in my chair lately that I'm low-key like, do you have sleep apnea? But you look at the chronic teeth grinder mouth and they've got so many crowns. Many crowns, usually like half a dozen root canals. And I just feel bad for them. Like, that is so expensive. Like, say the average crown out of pocket, if they have insurance, is like $600. But if you have most of your back teeth are crowned, it's so expensive. And a lot of times they end up needing full mouth restorations where it's like the 28 crowns. I can't even imagine how pricey that is. If we could get them when they're younger, they would have so much more money in their pocket and be able to do so much more fun things, like go on vacations or buy the boat or whatever.
One of our OG episodes with my patient Wendy, and one of the main things she came to me with was anxiety and panic attacks. That was her main concern, was the breathing, sleep, anxiety, and panic attacks. And she didn't have a tongue tie issue that we needed to address. She had low tongue tone, mouth breathing, and just that quality of her life changed. And she was in her 30s, and just, to have that anxiety and the panic for so long, like she got a new lease on life, which was amazing.
Yeah. And I think I see this with the tongue-tie adults, some of the tongue-tie adults that have their tongue ties released, and how they can sort of breathe better, sleep better. And it's a literal release of themselves. If we can only address that younger, so that people don't have to go through that.
Yeah, which is why this book is so great. I was kind of sitting here thinking about putting you on the spot and being like, what's your favorite chapter? But like, you wrote the whole thing, like every chapter is your favorite, right? And I'm just, again, I'm kind of looking through we've read the book, but just kind of looking through some of these like cases, you guys, like, it's the illustrations and I guess they're not technically all illustrations, but the images in here are so powerful. Well, of course, I was just in your myofunctional therapy section. But even, or just the palate expansion and just seeing, how much these kiddos have changed. I just think that is so, so cool. And I like how you have even some highlighted areas like this, just in this page. A child's greatest need for restorative sleep and peak window of brain development is before the age of 3 years old. Like, woof, like that. Like, my daughter's almost 2, you guys, right? And like and think about how many, parents struggle with their kiddos sleeping in those early years, and, conversations around sleep training and sleep and noisy sleeping and sleeping with your knees tucked and your butt in the air, right? The idea of how much development, especially of the brain, can happen by age 3 is just amazing and concerning all at the same time.
For sure. I think, was it 80 to 90% of the brain it's reached its adult size by age 3. So definitely something we need to pay attention to.
Yeah.
The breathing thing is so fascinating. I saw this post the other day. It was Stephen Lin. I love him so much. But it was like an MRI showing how the brain kind of moves, that brainwave cycle that we talked about with the Gillespie approach in the last episode. But when you breathe, your brain kind of expands and contracts, and it's like slowly kind of pumping. And I was thinking to myself, like, that is so important that we teach people to breathe with their diaphragm, breathing down low into their lungs versus like all shallow and rapid with the chest, like to breathe low and deep to get the maximum efficiency of that brain, and also like that pumping of the cerebral spinal fluid. It's such a beautiful, beautiful thing.
I was actually reading a colleague's book called Empowered Sleep Apnea. It's by David McCarthy, all about obstructive sleep apnea for adults. Very simple, clear explanations for adults that want to feel empowered about their condition and how to manage it. But he uses the word nasodiaphragmatic breathing. And I think I liked that. Maybe I'll use that more next time.
It's a mouthful.
It is. But it is really highlighting that is the optimal way to breathe.
Oh gosh, that's so true. Since we're talking about, and we've had a lot of different perspectives on here, the brain being 80-90% developed by 3, obviously we know early intervention is key. What do you think is one of the best ways for parents of kids under 3 to get started?
I think given that the jaw development is really important, and breastfeeding is one of the most modifiable influences, I think we need to promote the mechanical benefits of that, and really allow more people to be aware of the possibility that tongue tie could be the root issue of breastfeeding issues, and looking for optimal latch, not shallow latch, which may overuse the lips and cheeks. We want deep latch and proper tongue function, because breastfeeding really sets things up. And even nasal breathing, we can suck, swallow, breathe, and coordinate, so we don't need to stop and mouth breathe when we're feeding. So I think really that is one aspect, and just making sure that people if we can close babies' mouths where possible, because if they continue with the mouth open, they will most likely become a mouth breather in the first year, by the end of the first year of life. And just making sure they have a clear nose. So just all those type of things, munchy, chewing, just exercising and using the muscles well, because it's a functional problem with the tone of the muscles as well as the jaw problem. And there's not a lot we can do. Sometimes I see babies that are born with a narrow palate, and I just know that's going to impact their function and their nasal breathing, but you can't really do anything in that first 3 years of life.
We do lots of munchy and lots of nasal rinsing for Izzy. She actually she loves this.
She does.
Oh yeah. She loves it. She doesn't. We started with bogey spray. And she loved that. She's tried to do it on her own. And then when we recently had the flu, which was brutal, you guys, I don't recommend it. We did lots of this. Mommy did it too, because Mommy was also very sick in the bath, and she would grab it, she'd do it, and she loved it. And
I think what we need to see is more videos of things like that to normalize it.
Yeah.
to
I know.
make
I
sure
needed a third
parents-
hand or like to set up my tripod. I kept wanting to get videos of it, but then there's a little like wrangling of the toddler too. So
yeah.
but yeah, I do think that's right. I think we need to normalize a lot of this stuff, right? Like normalize using Munchie, normalize the using the nasal rinsing. I think it was Aaron, I think Aaron, my associate, sent me like a video of a smaller baby with a syringe, and like half the comments, you might have too, Kimmy, half the comments were like, oh my God, how could you torture your baby like that? And it's like, whoa, like letting my baby breathe is not torturing my baby, right? And the other half was like, oh, this is awesome, this is such a great tool and tip. And so just that education piece of like saline nasal rinsing your baby can be really, really helpful.
And not child abuse.
Yeah, I mean, there are always going to be parents that feel that when they do a spray, it's quite traumatic, but definitely to get the tips and learn from you, I think that would be fantastic.
Yeah, yeah. Oh yeah, Izzy baby loves having her nose cleared. She doesn't like her boogers picked, but she likes her nose rinsed out, right?
Yeah, that's cool. Yeah.
Oh, I love it. Well, gosh, thank you so much for joining us today. Where can people, well, a couple different things. Where can people find your book?
The book is, the easiest place is Amazon.
There's
quite it's available in most marketplaces. And there's a lot of other, if they just Google it, they'll find lots of other booksellers in their area.
Beautiful. I love it. And if people want to follow your practice and follow you, what's your website? Are you on social media? How can they find you?
Yeah. My website is drshereenlim.com.au, but where I'm most active is going to be on Facebook, Dr. Shereen Lim.
Beautiful. I love it. I love it.
And is it doctor with a D-R or doctor?
DR.
Perfect.
Yeah.
Good question.
So I just got an email from my web company. I think they're going to be releasing the website soon, but there's a landing page there. So I hope to be able to continually put new information out, because this is important information that parents need to be aware of, to be able to create resources that other practitioners can use as well. I think that's my aim.
Yeah. I love it. All right, you guys. Well, of course, if you
thank you so much, guys.
Oh, yes, thank you. Oh, yes, thank you.
I loved your energy.
Doing the Lord's work. If you guys want to find us, you can find me at NWMFT. You can find Kimmy at Mouth Muscle Memory, and you can find our podcast at the Munch Bunch Mayo podcast. So another Munchie Monday success, and we can't wait to see you guys next time.
Yeah, thank you.